This is Dr. Garais. This is BIO111, Anatomy and Physiology, and we are now doing today Chapter 8, which is joint spaces. Okay, so joints are articulations. They are the functional connections between bones, and they're part and parcel of your skeleton system. So, and we already know the part of the epiphyseal part, epiphyseal plate slash epiphyseal line. That's the ends of the bones. So this joint space and the ends of the bone is a pretty delicate and pretty important area because that's where growth happens. Okay. And also that's where also movement happens. So you have classifications. Now, if you have structural, which is of course anatomical, and functional, but when you really look at it, it's the same thing. So let's look at the structural first. You have fibrous, and we already know if something is fibrous, it's dense. Does it move around a lot? Nope, right? So it's tough. Cartilaginous, we already know about cartilage. Cartilage in our pubic symphysis and cartilage in our intervertebral disc and cartilage in our ribs. They move, but they don't move a lot. But synovial, like your arms and your legs, your knees and your elbows, that moves what? Moves quite freely, and it's the most complex structure. Remember when we looked at anatomage, when we looked at the kneecap? Remember we were like messing with it, and then they had all these straps and all these connective tissue. So when we're looking at structural classification, you have something that's what? Fibrous, right? It's dense, it's hard, cartilaginous, right? Held together, of course, by cartilage. And synovial, it's a very complex structure. And we know a little bit also about synovial as well. If you recall your medical terminology, they have pockets of fluid, and the pockets are called bursa. Bursa for singular, bursae for multiple. So that has to do with the pockets of fluid, and this stuff is called synovial fluid. So you have fibrous, cartilaginous, synovial. Now those are the structural classifications, but they kind of match up to the functional classifications. So you have synarthrotic, amphiarthrotic, and diarthrotic. Use your medical terminology powers. Syn means the same, right? Means that joint space will not move. It's immovable. So if you match it up to the structural classification, it's most likely fibrous. It's dense and it won't move. Amphiarthrotic, when something's amphi, right? If something's amphibious, it's not only the water, it's not only land, it's kind of both. So something that's amphiarthrotic is slightly movable, which matches up to the structural classification of cartilaginous. Because remember those three cartilages that we just talked about, we saw in anatomage, your intervertebral disc, your cartilage, your costal cartilage on your ribs, and your pubic symphysis. They're slightly movable. They move a little bit, not a lot. Therefore, the amphiarthrotic functional classification kind of matches up to the structural classification of cartilaginous. And last but not least, dia means complete or thorough. Complete or thorough what? Movement of my arthur, right? Remember arthritis, inflammation or infection of a joint space. Arthur is the root word meaning joint space. So a diarthrotic joint is also a synovial joint. It's freely movable. So if you look at my arms and legs, they can go in any direction. But if you look at my back, it doesn't go a lot of places, right? And when I breathe, right, my chest doesn't move a lot of places. So those are cartilaginous. But diarthrotic, synovial are ones like your knee, your elbow, your fingers. They move all sorts of different directions. So of course, fibrous joints. And remember we talked about keratin and collagen? Keratin was where? Right on top. But collagen's where? Deep. So where are my fibrous joints? They're deep in the connective tissue, right? And you have three types of fibrous joints: syndesmosis, sutures, and gomphosis. So what's a syndesmosis? It's a bundle of dense connective tissue or interosseous ligaments. Interosseous. Inter means what? In between. Osseous means bone. Remember when we looked at the radius and ulnar? Do you guys remember anatomage? There was a band of connective tissue in between it. Remember we looked at the tibia and fibula. Remember there's a band of dense connective tissue? And that's an example of a fibrous joint called a syndesmosis. And syn means what? The same. So you see here, this is not moving anywhere. This shouldn't move anywhere because these things are what? They're connected to each other. And since they're connected to each other, remember we talked about in anatomage, if I fracture my tibia, right, your shin bone, what are the odds you're gonna also fracture your fibula? Pretty good because they're connected, and they're connected through this dense connective tissue called syndesmosis, also known as your interosseous membranes or interosseous ligaments. And remember ligaments. Ligaments connect bone to bone. Tendons connect bone to muscle. Amphiarthrotic, flexible, may twist, right? Now, what are some other examples? Suture. Remember the skull? Your skull had all those little jaggedy lines. So when you were a baby, you had a soft head. You had fontanelles. You had actually a hole in your head, right? But what happened? When your skull started to grow, they started growing together, and then they started fusing together. Even if I'm doing this, the only thing that's moving here is my scalp. Does my cranium move? No. So that's a suture. It's a fibrous joint. It should not move at all. And last but not least, what are your gums? Those are your gum fossa. So what's in your gums? Teeth, right? Your teeth, in theory, shouldn't be moving around a lot. These ones down here don't look good. The ones on the top, I don't know. Right? But gum fossa or your gums or your teeth, the joints of your teeth should not move. Okay? So this is how I remember. Gum fossa sounds like gums, right? Sutures are the sutures in my skull. And of course, syndesmosis are my interosseous ligaments, like the ones found in my radius and ulna and the ones found in my tib fib. Here's some sutures, and here's gum fossa. And you can see, even a tooth, it's not just, it's an actual living thing. It has arteries, veins, and nerves in it. And that's why when you pluck them out, it kind of hurts. Now, cartilaginous joints. Hyaline cartilage or fibrocartilage. What's so special about cartilaginous joints? We already talked about 3 classic examples of cartilaginous joints. And one of them was your costal cartilage. Costal, al, pertaining to your ribs. Your ribs and your rib cage and your thoracic cage has to move a little bit upon inspiration. And of course, upon expiration as well. We also talked about your intervertebral disc. It is a piece of cartilage that's in between your vertebrae. And last but not least, next page, your pubic symphysis. The pubic symphysis, oh, here. Better look at this, cartilaginous joints. This is better. And you see, I got my rib cage, my pubic symphysis, and my intervertebral disc in between my vertebrae. This is a better thing to look at than words. So these are all what? Cartilaginous joints. Do they move? Yes. Do they move a lot? No. They move just a little. Just enough flexibility. And even sometimes, like I stated before when we did our anatomage, the pubic symphysis right here, especially if baby gets really big, can even actually separate. And you guys know about if you get a slip disc. See these things, they're called pedicles, right? And these little arches, they're called the ramus or rami. There's nerves that go in and out of this thing. So you could see if this thing moves too much or it slips out of place, like a slip disc or a herniated disc, don't you think it's going to cause either pain or numbness? Either way, it's not a good thing to have a slip disc because it messes up your nervous system. Now, last one, synovial joints. That means what? Diarthrotic. It means things that I can fully move. And the big thing about a synovial joint is it's complicated. So it has a lot of protection features in it. And we saw the classic synovial joint is your knee joint. And did you see all the ligaments on anatomage? There's all these things going left and right, up and down. There's some on the sides, some on the top. There's what they call a cruciate ligament that crosses in the front, posterior cruciate ligament that crosses in the back. So many complex things because this knee is moving in all sorts of directions. Okay, so there's a lot of ligaments. And the one big thing that the synovial joint has is they have this thing, this pocket called the bursa. And that's what that synovial membrane is. And that pocket holds this fluid called synovial fluid. And that's what gives you the ability to have full range of motion, or what they call in orthopedics ROM. ROM is range of motion. And there's actually an angle number regarding range of motion. Maybe you guys have seen it, like they put a brace on you, and then there's like a little protractor, and then they make you do movements, and the physiatrist has to write those numbers down. So remember when we were in high school, we said, when am I ever going to need geometry? And then when I got to my physiatry class in medical school, I'm like, oh, this is when I need it. Articular cartilage, joint capsule, and that capsule, right? It's a pocket, and the pocket is called a bursa. This synovial fluid gets recycled out and should be relatively sterile. If it gets dirty for whatever reason, don't you think we're going to get something called arthritis, inflammation or infection of what? The joint space. Meniscus, bursa, right? And let's show what those things are. Remember, bursa means pocket. So let's look at this. If you look at the knee, in order for this thing to move, it's kind of complex. Because if we saw the cartilage, it's just what? Cartilage connected to a bone, end of list. If we saw the sutures, gomphosis, it's just what? Connects in and bone to bone, and it shouldn't move. But if you look at this, the outside part, of course, is what? Tough. There's got to be a fibrous capsule. And then you have a synovial membrane or a synovial skin, and then it forms this pocket here. And this pocket is called a bursa. Bursa means pocket in Latin. So maybe you've heard, maybe you had an older family member who had bursitis. That means they have what? They have a form of arthritis that's affecting this pocket. And this pocket here, if it gets in, it's pretty much sterile, but if it gets infected, it's going to cause inflammation. And then you know with inflammation, you got pain, swelling, and all these bad things. Now, goes, what is it? What is a meniscus or menissa? Menisci. You see here, there's like, I don't know, they're like pads that also act just like your articular cartilage to, again, this thing's fully movable, and also it's taking on a lot of weight, especially regarding your knee. So the menisci, right? They're kind of like little wedges that keep all of this fluid here. So now you can see here how kind of complex all of this is. It's not simple because a synovial joint has multiple movements and has to have multiple areas of not only protection, like your meniscus, like your articular cartilage, it also has multiple areas of where there's synovial fluid. And again, too little synovial fluid, what's gonna happen to the bones? They're gonna start rubbing together. Too much synovial fluid, you'll have edema, you'll get swollen up. And those of us who ever had swollen joints, how well do you move? You don't move very well when this gets swollen up. And then now you can see how easily we could do arthroscopic surgery. You just drill a hole in the side of your knee, and then we do what? We can do anything we want here. We could repair all of this and take things out, put things in. So what are some examples of synovial joints? And these are the ones that you learn maybe in health class in high school. You know, when they start talking about ball and socket joint, condylar joints. And what's the classic ball and socket joint? The classic ball and socket joint is your hip joint, which connects your femur, and this ball part is called your acetabulum. And the socket part is part of your ilium. You also have a condylar joint. Now, what's a condylar joint? Think of it, it's kind of sliding. So when you see your fingers, right, they can do this sideways, and of course they can flex and extend. So that's an example of your and phalanx is a singular finger. Phalanges is plural. Plane joint, think what? My wrist. And again, my wrist does what? It slides. Hinge joint, I want you to think flexion and extension. So what's the classic? The classic flexion and extension. And what's flexion? Remember, we're going to do some geometry. Remember this angle here? 90 degrees and 90 degrees, that's 180 degrees. And what happens when I'm like this? Then it turns 90, then 45, and then less than 45. So when I'm flexing, what's happening to the angle here of this joint space? It's getting what? Smaller. But when I extend, it's the exact opposite. The angle is getting what? Bigger. So that's your typical hinge joint. That is a synovial joint, right? And so if I ask, what's a hinge joint? And you'll tell me it performs flexion and extension. It goes, what's a plane joint? Think what? Your carpals. Pivot. You guys know anything about Friends and the moving furniture? Your pivot joint. Now, you can see when you pivot, you're doing what? You're doing this. And remember, who does that? That is, of course, your vertebrae. And it only goes so far. Now, we already know we have 7 cervical vertebrae. Now, let's talk about cervical 1 and cervical 2. Cervical 1, if you see here, that's your atlas. Your atlas is like a hinge joint. Your atlas says, I can nod my head yes or no. So doesn't this look like flexion and hyperextension? Flexion, hyperextension. Then that's what? That's a hinge joint. But the axis, the cervical bone, cervical vertebrae number 2, that gives you the ability to do what? Say no. And that is the pivot joint. Okay. And it's also the reason why you can't spin your head all the way around. Because of course there's stuff connected to it. You only can spin it what? This way and that way. Okay. So what kind of question could come out from there? I could ask you, your cervical 1, is it your atlas or your axis? Cervical 1 is atlas. And this is how you remember it. You remember who's that guy who holds the whole world in his hands? And he's like this. He's that really buff dude, and he's holding the world like this. If you're holding something up like this, don't you think it's going to hinge up like this? So that's what? Atlas. And of course, axis, you're spinning what? On your axis. So that's what? Cervical 2, left and right. So if you're, how's this? If your patient can't move their neck from left to right, what fracture are we entertaining? C1 or C2? C2, which is of course what? An axial or axis fracture. If my patient can't flex their head, and of course, what happens to the angle here? It's getting smaller, so that's flexion. What's happening to the angle here when I do this? Extension. And remember your CPR, what do? We're hyperextending my patient's trach. So that is what? Cervical 1 versus cervical 2, and that's for your pivot joint. Saddle joint, nice to know, and it's your thumb, and it rides like a saddle, and that's why your thumb can do this, right? And it doesn't do this very well, but it does this very well. But nice to know. Origin and insertion. If you have future training in anatomy and physiology, these two words will plague you. It's a very horrible thing. Every muscle has an origin and it has an insertion. So does and it matches, like skeletal muscle has to match up with, of course, the skeleton. So right now we learned what? Humerus. You don't want to know the 23 other connections that the humerus has to the rest of your body, right? But know this: motion is based on these two structures. You have an origin, which is fixed, and insertion. So if you look at when I flex, we already know this is flexion, right? 180 degrees, 90 degrees, 45 degrees. When I flex, you notice that my elbow isn't moving a lot, right? That's the origin, right? And those, if you look at the rest of the arm, it's moving a lot, isn't it? So the origin is the point or the fulcrum where it's not moving a lot. And the rest of it is the insertion, right? Which is the movable part. Who's going to get more hurt? The one that doesn't move or the one that moves a lot? The one that moves what? A lot. So knowing your origins and your insertions, right? Origin will be stabilized. And during any trauma or whatever, that's the thing that's probably not going to get hurt. But what will get hurt? The more movable end, which is the insertion end. Right? So let's look. Let's say I got tackled by somebody, right? Not going to hurt my elbow. What's going to get hurt? Wrist, fingers, thumb, all this other stuff. That's what? The more movable part. Between proximal versus more distal. So let's talk about that same tackle. Which is probably going to get hurt? My shoulder or my elbow? Odds on my elbow, because that's the one when I'm raising or lowering my arm. You see the origin here? It's not moving a lot. But you see this? This is moving a lot, right? And that's why in baseball, right? This thing will get hurt, but you know, it goes, what will get hurt first? The elbow is going to get hurt first before this. But when this starts getting hurt, when your shoulder starts hurting, that's not good. Flexion and extension, we already know that one. We already know those movements. Hyperextension, I want you to think what? Head. So this is flexion, extension, hyperextension. Lateral flexion, of course, is bending side to side. Now, that's easy. Lateral means what? Pertaining to sides. Doing a dance. That's what I'm doing today. Now, what's abduction versus adduction? If you look at this thing right here, think about the word abduction. When you're abducting somebody, you're pulling them what? Away. So abduction means I'm pulling the limb away from midline. Okay? And adduction is the exact opposite. I am now adding the limb to midline. And there's different muscles that do different things. So you have muscles in, we're going to be talking about next laboratory next week, right? Your abductor muscles in your thigh. That's got to be the muscles that pull your thigh what? Away from midline. And you have adductors. Those have to be muscles that are going to pull your thigh where? towards midline. Flexion, extension, flexion, extension. Now, when you do flexion extension, of course, your arms and legs move a little bit different, right? And it makes sense. There has to be balance. Imagine if your arms and legs move the same exact way. How backwards would that be? There has to be balance. Like your arms flex where? Anteriorly, but your leg also flexes, but it flexes where? Posteriorly. So it gives a nice little balance. But if you've ever seen anyone with bone and joint abnormalities where their hinge joints are backwards on their knees, how well do they walk? Not very, because the balance is off. So flexion and extension. I'm way too happy to be in this. Now, this one's really important because, oopsies. There's reflex testing called Babinski planar. Babinski plantar. Anyone ever been tickled in their feet in the emergency room for whatever reason? Like the doctor usually takes a pen or a pen light and they stroke the bottom of your feet. Then they don't tell you. I don't understand why neurology does that. Neurology just starts touching you and you're like, yeah, we have to check. Now, why are we checking? Because if I do that, right, I'm gonna run a pen, it goes underneath your foot, right? And remember that the top part of your foot is your dorsum, and the bottom part of your foot is what? The plantar part of your foot. And this is how I remember it. If I plantar flexion, I'm planting my foot into the ground, right? And dorsiflexion, where's the dorsum of my, it would be just the exact opposite. Now, what happens in a Babinski plantar? If my patient has a transection of their spine, instead, typically if I do this, what will you do? You'll plantar flex, right? You're like, ooh, that tickles, and you'll point your toes. But if I do that to somebody who has transection of the spine, they'll fan out their toes like this. And also, they probably won't feel what you just did. That's the scary part. Circumduction, that's easy. Circum means what? Round. So you do that this. Supination and pronation. Remember supine and prone? Well, this is like the more complex way to show it. Anatomic position is like this. If you've ever seen that naked view, the one with the Da Vinci did, it's like this. Their palms are faced this way. So if I put my palm down, don't you think I'm what? I'm prone, right? So this is how I remember it. Palm down, prone. And the other one is simply what?
The other one.
The other one. Because if I'm like this and I'm supine, and that's actually patty cake, isn't it? And that's actually, oh, you should see how irritated patients get when you make them do patty cake, because I have to see, it goes, if the coordination part of their brain is intact. So I'll be like, sir, ma'am, first thing I do is like, can you grab my fingers? And then we see the level of strength, if it matches, left and right matches, and then it goes, okay, can you put your palms down and do this for me? It goes, okay, and then like, hey man, are you messing with me? And I'm like, no, I'm sorry. And then you ask them questions like, what year is it? Who's the current president? Who am I? And then they get really irritated. They're like, no, I'm not answering any more of your questions. But that is your mini mental status exam. All those little things and all these movements, not only neurology does it, but orthopedics does it, because we don't know what kind of movement problem you have until we actually test it. And then, of course, sports medicine will actually have it's called a goniometer. It'll actually measure your range of motion. Lateral rotation, that's easy. These guys are just way too happy to be where they're at. Lateral rotation is where? I'm gonna do what? I'm gonna go hitchhiking. And my arm is gonna go where? Laterally. And what's medial rotation? Now my arm is gonna go where? Inside or towards the middle. All right, ladies, those of you who love wearing your 4-inch heels at the club, you know inversion and eversion. Inversion, of course, is what? When you sprain your ankle towards where? Right? And eversion, when you sprain your ankle towards what? Out. Think about it. In. When you have eversion, that's what? Evasion. When you evade, you're going where? Out. Protraction and retraction. Oopsies. Protraction and retraction. Pro means what? Forward, right? And re means what? Backwards. So protraction is putting your head forwards, right? And retraction is pulling your head backwards. And again, it's also testing what? Your cervical spine. Okay, also tests a whole bunch of other nerves. Another thing I also make my patient do on a mini mental status exam, I make them stand up straight, and then I ask them to do what? Because you have elevation, and we're looking for symmetry, right? Because when you raise both your shoulders up, if you have any nerve damage or any muscular damage, don't you think it'll be a little bit off kilter? Or if you have scoliosis or whatnot, it's gonna be a little bit off, right? And then, of course, depression. And I also make them do that, in my mini mental status exam, I make them do that with their jaw. I make them protract, right? And then we do all these other things, make them stick out your tongue. Because your tongue's a muscle, right? Look at somebody who has palsy. Make them stick out their tongue. Their tongue will point in the direction of their palsy. It's really neat, right? My son has what? Palsy left. He cannot stick his tongue midline. Like, fix your tongue. And he'd be like, I'm gonna fix it. And he'd be like, okay. And I'm like, oh, okay. You still have your palsy, I guess. And he was like, oh, I mess with them all the time. But when he was a baby, I did every neurologic on my son. And it all came out positive. But it's neat. At least we can mess around with them. Large complex synovial, we know all that. And of course, at the very, very end, lifestyle changes, what? Everything gets what? Worse. All right. So with that being said, that is chapter 8. And then, like I promised, I will make a